Hey everybody, Dr. Shook here. Hope everybody's doing well today. Happy 4th of July if you are in the US, and if you're elsewhere around the world, hope you're having a wonderful day. So what I want to do is I'm literally going to do 10 minutes here. Like I'm watching the clock, I'm going to do 10 minutes. But every time throughout the week as I'm working with people or as I'm studying a particular topic, I'll remember something or I'll learn something new that I want to share with everyone in a live stream and a video. And that's one of the things that happened this week. So I was working with someone the other day and we were reviewing some test results. And my client had a history of hormonal imbalances, of thyroid-like symptoms, though the thyroid looked normal. There were definitely erratic signs of what seemed to be almost hyperthyroidism, like increased heart rate, anxiety. There's a history of significant history of cancer throughout her family. There is a significant history of endometriosis, of hormonal problems, seem to be around the menstrual cycle. So just a number of different things that are going on. And so, with those symptoms, it can be very difficult. It's really impossible, quite frankly, to do a great job just based on history. Just to sit there and try and figure out what's going on with that person based on history. It's really not the best thing to do. What you really want to do is try to get some biomarkers. So what we did is we did some testing and we looked at her hormones, we looked at her digestive tract, we looked at a very broad metabolic analysis of her health. So we looked at inflammatory markers and all the things that I think are essential to look at very foundationally for every single person that you have to assess. So we looked, interestingly enough, we looked first at the foundational biochemistry, okay? Which, when I say foundational biochemistry, this is nothing that your doctor has ever ordered for you because it's a very expanded panel, but I call it foundational, so it sounds basic, but it's far from basic when you compare it to other panels because it looks at every system of the body we can look at. That's a bit of an exaggeration, but it looks at a lot. Okay, so we looked at inflammatory markers and red and white blood cells and the liver and electrolytes and blood lipids and 10 different thyroid markers and inflammatory markers and a urinalysis and blood proteins, systemic enzymes throughout the body. I mean, we looked at a lot of things that are really critical and that can give you insight into what's going on, right? You survey because a lot of these problems and symptoms that people are having, you can have the same symptoms with a lot of different causes. Okay, so a lot of different problems can result in the exact same symptoms. So you have to cast a wide enough net and look at enough physiology to try to figure out what's driving these symptoms, or you're going to be treating symptoms only, right? So what we did was we cast a wide net. So with this initial blood work, we found out that there was the thyroid hormone markers looked fine. They all looked fine, right? Like TSH was fine, thyroid hormone levels were fine, but she was having all these symptoms of high and low heart rate. Literally went to the doctor to wear to the doctor, and they recommended the heart monitor for 30 days or something, right? Turns out that was all normal. So what I ended up seeing here, and this was even before the heart monitor, was that something called T3 uptake was low. Okay, so T3 uptake was very, very much on the low end. I don't know if it was lab low, but it was very, very close to being lab low. So T3 uptake, when you see T3 uptake is low, you have to look and see if the quantity is normal or not, right? If the T3 is really low, then the uptake is going to be low. But if the T3 uptake is low and the quantities of the hormones are normal, then you have to say, okay, what's going on here? Why is the body not uptaking as well? And so one of the reasons that you'll see a lower T3 uptake is because of high estrogens. Okay. Now I already told you that there was a all kinds of hormonal issues, family history of cancer, a lot of other things that can be associated with higher estrogens. So I was like, okay, this looks like an estrogen-based pattern here with your thyroid hormone. So remember, there are 4 phases of all hormonal physiology. There's production, so do you have enough of it? There's transportation, so can it get through? Can it be carried in the blood on these little carrier proteins to where it needs to go in the body and be used? Then there's sensitivity at the cell. Once the hormone gets to the cell, can the cell use it? And then can it be detoxified and eliminated from the body? Because that's an important step. That's a very important step, which we're going to talk about here. So she's breaking down, if I'm right, based on this blood work, then she's breaking down at transportation. She cannot carry, because the estrogens are higher, she has more of these little carrier proteins in the blood. Those carrier proteins bind up more of this free hormone. They bind up the thyroid hormone and hold on to it so it stays in the bloodstream, but it's not freely floating and available for the cells of the body to use. There has to be a balance. If you have a lot of these little carrier proteins in the blood called thyroid hormone binding globulins, okay, it's a blood protein called a globulin. If you have too many of those or a high number of those, you're going to bind and hold on to all of the thyroid hormone, or to a lot of the thyroid hormone as a percentage more of it than you really want to be bound to protein. So what happens is the thyroid hormone will have an affinity or an attraction to what there's more of. So higher estrogens tend to increase these thyroid hormone binding proteins, and you'll bind and hold on to more of your thyroid hormone. So when you look at your production, you look at the quantity of the hormone, remember that's phase 1, production, everything looks normal. So unless you are aware and you acknowledge the fact that there's more than just the quantity of hormone, unless you acknowledge the fact that there's transportation, there's sensitivity at the cell, and then there's detoxification elimination, you miss 75% of the physiology. And if you're only looking at production, which is what we look at from a medical perspective today, and it's inadequate and it's outdated, and I've said it 100 times, or more, probably more. We got to do better than that. Though that is an extremely important piece of the puzzle is production, because so many people suffer with low production, and so many people do much better when the production's increased via a hormone replacement. So, not trying to be hard on any of our doctors, nurse practitioners, physician's assistants, anyone prescribing medications to help people. They're doing an awesome job helping folks. You can't expect them to know what I'm telling you. So don't be hard on your doctors. You can't expect them to know what I'm telling you because they're not trained in what I'm teaching you. Neither was I. This is all through a lot of personal experience, a lot of personal suffering through trying to figure out how to do things, and then ultimately working with people to try and help them to help themselves, and then learning from some really, having the opportunity to learn from some really great teachers. So she has a transportation issue. Remember, production, transportation, sensitivity, detoxification. High estrogens, more of these binding proteins. She holds on to more of the thyroid hormone in circulation, so then it's not available for the body to use. You would never see this on a test unless you checked like the uptake, or sometimes the uptake doesn't even show this. But you've got to look at the history, and then you've got to understand some of these physiological breakdowns. So here's what I suspected. Okay, this is what I suspected was going on, and I said, look, here's the deal. How are your estrogens, or how's there's also a connection here to the gut. So, and we had some digestive problems, and she also had so when I do my initial the foundational blood work, I also looked at the white blood cells, and I saw that the white blood cells, one of the types of the blood cells as a percentage was high. They're called eosinophils. Okay, so they're high as a percentage. So when you see that, the first things that I'm thinking about are, okay, I'm thinking, is there a parasite in the gut? Because eosinophils will go high with parasites. And then I think, is there a food sensitivity based issue? Or environmental allergens, okay? Really common. Definitely had a history of environmental allergens. So I'm like, okay, so it's probably environmental allergens, but could it be a parasite? There's definitely gut issues. Are there food sensitivities? So we talked about it, and she's like, okay, well, let's do some additional testing, right? Because I was like, we have some information now. We could start with we have a better starting point now. We understand what's happening here a bit better because of this data. But it would be more helpful if we had additional testing. And so we did do some additional testing. We did a stool panel, And then we did a cortisol and hormone profile. So we looked at those two tests to help us fill in some of the pieces of the puzzle here. Because I wanted to know from a hormone profile, are there high estrogens? I wanted to see what was the state of the adrenal physiology. What's the cortisol physiology like? Because that's your stress response, but you can get a window into stress response there. And then I wanted to know what was happening with the gut, because there were a lot of digestive symptoms. And by the way, on the initial foundational blood panel, the C-reactive protein, which is an inflammatory marker, was lab high. Not a good thing. If you follow me and you listen to what I've talked about numerous times regarding what are the most important tests to address first. Like if you bring me a stack of blood work or labs this thick, I'm going to say, where are the inflammatory markers first? That's the first thing I'll look at. And I'll turn to those inflammatory markers and I'll see if they're high. And if they're high, I want to know why. What's driving the inflammatory chemistry higher? So, because it disrupts so much physiology. It's like to me, it's the super priority. Whatever's driving that is the super priority, because it's going to disrupt so much other physiology. So, her inflammatory markers were high. And then I wanted to know why is her inflammatory level up? Her white blood cells were not high, which you think if someone has a high inflammatory level, that's due to an immune response. What's driving the immune system? So the only thing that we had were, what are her symptoms, and then did the white blood cells show us? Because you can look at white blood cells and the different types of white blood cells as a window into what might be driving the inflammatory markers high. We had some systemic enzymes, which are important when you're looking at inflammation. But we didn't have any smoking guns, so to speak, right? We did have those eosinophils as a percentage that were shifted higher, and then we had symptoms. So we got the additional testing. We got the stool panel. We got the cortisol and hormones. So I wanted to know first of all, are the estrogens high? Sure enough, we got the hormonal panel back. Estrogens were high. It's like, okay, this makes a lot more sense based on the symptoms that you're having around a menstrual cycle, all the female hormone issues that were going on, family history. There's probably a genetic component to that that's contributing to the estrogens being higher, though there are many reasons that these estrogens can be higher other than just genetics. And then, there was also, as a component of the history, there's hair loss, okay, which is a huge, huge complaint that we see very commonly with thyroid-based problems, right? Hair loss is a huge issue. So many women are very, very concerned about this. So, one of the things that with hair loss, there's a lot that you have to look at to really try to nail down what's driving hair loss. And I actually created an entire guidebook on trying to understand that. It's like 29 pages, and I go through like a ton of different tests to try to give you an overview of like what's involved in trying to understand hair loss. So with her, it's a big issue. So we didn't know even with the foundational testing, and sometimes you just don't know exactly what's causing the hair loss. But with the hormonal testing, we checked a hormone called dihydrotestosterone, or DHT, and her DHT levels were lab high. Now in men, that contributes to prostate hypertrophy and male pattern hair loss. So this is a big issue for her. And I was like, look, the DHT is an absolute contributing factor to hair loss. So there's some tools that we can use to address that, but we ultimately want to address the cause of the high DHT, right? We don't want to just say symptomatically, let's take like saw palmetto and some things that can help to try and decrease the enzyme that helps to produce that. So, but we're going to approach this as many ways as we can, but we're always looking for cause, for driving factors, which I think is the inflammatory load. That's what I think is doing it. Her high inflammatory levels, which is why does she have a high inflammatory level, right? That's the thing we're trying to track down as well, because it's all connected. That's why I'm talking about all these different things, because they're all connected. So hopefully I'll pull this together for you here as we get to the stool panel. So we get to the stool panel, and her stool panel, she has lab high opportunistic bacterial overgrowth. She has lab high candida, which is yeast overgrowth. She has low normal bacteria, which means there's dysbiosis. There's an imbalance in gut bacteria. And, we were talking about it, and she's like, why does this happen? And there's, when you start looking at the literature on GI tract bacteria, the gut is very sensitive to stress, environmental chemicals, to the different types of foods that we eat, to antibiotics, to different medications. And when we talk about stress, what is stress? Well, stress is lack of sleep, emotional stress, physical pain, anything that drives a sympathetic nervous system response and contributes to increased cortisol and catecholamine output. There's a lot that can disrupt our GI tract bacteria. And so there are a ton of different things that can do this. And then that, loss of normal gut flora sets the stage for what I think about it as almost like weeds growing into a grass. Like they'll grow very quickly given the opportunity. So you disrupt the normal gut flora, these weeds grow in, these opportunistic bacteria, this yeast and candida will grow in. And then you've got a problem. Then you've got dysbiosis. And so we see this dysbiosis. And then I'm scrolling on down, I'm looking at the stool panel, and I notice that there's a high level of an enzyme called beta-glucuronidase. Now, your body makes it naturally, but bacteria that are opportunistic can also contribute to higher beta-glucuronidase levels. Now, beta-glucuronidase can be a real issue. Hers were 2 times the laboratory range on the stool test. And beta-glucuronidase is, in particular, it's a problem when you're seeing hormonal issues, because one of the things that it will do is when your body is breaking down estrogens. Okay, so every hormone in the body has to be metabolized by the liver. It goes through phase 1 and phase 2 detoxification pathways. Okay, that's just the biochemical pathways that the body will put these hormones through to break them down, metabolize them so they can be eliminated in the stool. And the phase 2 detoxification pathway, there's a process called glucuronidation. Okay, your estrogens go through this glucuronidation, this glucuronidation phase to make them water soluble so they can be eliminated by the body, because all hormones are fat soluble. They have to go through these phases to be made water soluble, so you can urinate, defecate, and sweat these hormones out. Okay, these things out. So then once they're made into this water soluble form, they're put into the bile. Okay, the gallbladder, right at the bottom of the liver. And then when your food, as it leaves the stomach and comes into the small intestine, the acidity triggers the release of bile. The bile is then released into the food, and the bile helps with the emulsification and absorption of fats. It also is transported out, what remains in the food, those byproducts, those estrogen metabolites, which once the estrogen goes through phase 1 and phase 2 of the liver, they become metabolites, broken down partial pieces of the estrogen, the estrogen hormone itself. So it's a part of the estrogen hormone. So we're talking about things like 2-hydroxyestrone, 4-hydroxyestrone, 16-alpha-hydroxyestrone. And there's different metabolites, okay? So a part of the original hormone. But it is now has a molecule attached to it that allows it to be water soluble. So it gets put into the digestive tract, and a lot of that should be eliminated in the feces, right? So you're getting these hormones out of your body. You're getting them out of your body. Well, the beta-glucuronidase can break that glucuronidation, detoxification pathway, can break the bond, and that makes it water soluble, and then you can reabsorb it. So she had really, really high levels. She was having all of these issues with female hormones, and we see this side effect. This poor uptake in the blood of the thyroid hormone, all points to an estrogen issue. So this beta-glucuronidase, I suspect, is a big factor here. So, and I suspect that the beta-glucuronidase being high is because of the bacteria, the fungal overgrowth, the dysbiosis in the digestive tract, right? So, which could be coupled with maybe some, with likely, we didn't check aromatase enzyme activity, but that's where your androgens, like your testosterone, is converted into estrogen at a high rate due to an enzyme that's high. We see this really high in insulin resistance. We see aromatase activity very high in higher inflammatory loads. It tends to be higher. So you've got to remember this, ladies. All of your estrogen was first an androgen. It was first testosterone or androstenedione, and then it's aromatized, even in the ovaries, into estrogens. So if you're making testosterone or you're taking testosterone, you've got testosterone that you're taking to try to raise your testosterone levels, you need to be really aware that if your doctors aren't aware of how this physiology really works, and they're just testing testosterone, like, yep, your testosterone's low, you need testosterone. Well, you need to understand that testosterone may be low because you're converting it into estrogen pretty quickly through aromatase. And it may not show up as high estrogen because you might be eliminating the estrogen pretty quickly or efficiently, or your body may be converting it into and breaking it down and metabolizing it and putting it into these metabolite forms that don't show up as straight estrogen. Okay, they don't show up as estrogen because they're a metabolite. It's not estrogen. You can't check estrogen and determine your estrogen metabolites. So you've got to understand, you really have to understand and look at this whole physiological process, I think, to try and understand the adaptive physiology that's occurring with the person before you go randomly saying whether or not a hormone is reasonable for them. Because if there's just more to it than look, it's just like the thyroid, where you look at the 4 different phases of physiology. You need to look at all 4 phases of physiology before you start making a judgment on what's appropriate or what's happening. Because not everyone, but most people are looking at your hormonal physiology as quantity only. That's not how it works. It's not just production. There's transportation that can break down. There's sensitivity that the cell can break down. There's detoxification that can break down. And if you're ignoring these things, especially when it comes to estrogens and sex hormones, I think you're really putting your health at risk there. Because if you're making too much of these estrogen byproducts and they're not being estrogen metabolites and not being eliminated properly, you may be putting yourself at risk for cancers and tissue proliferative disorders, because we know that these estrogen metabolites, like the 4-hydroxy form of estrogens, it's carcinogenic. The 16-hydroxy form has been associated with tissue proliferation, cyst formation, things like that. So there's a lot more to it that needs to be looked at. And that's where, like, this particular case, I was looking at this and I was like, this is a great example of how the gut can contribute to higher estrogens. It looks like, especially with the family history of cancer, I wonder if these were estrogen sensitive cancers. And we've got to try to look at the whole person. You can't just do this looking at quantity of hormones. There's a lot more to it. Well, you can do it, but I don't think it's wise. So this is where I think it's really important to try to just understand the physiology better. That's what, people ask me, well, what do you do? Well, I just try to be a better physiologist. I'm not doing anything new. What I'm trying to help people with here is just try to look at their physiology more thoroughly. And it's one of those things where it's just complicated, but you've got to understand that there are these connected pieces that have to be considered. So with this particular case, with all of these symptoms that we see, with these gut problems and with these hormonal imbalances that we see, it comes back to okay, what do you do about all this? Well, so looking at the whole picture now with the testing that we have, here's my take on it. I think that she the first thing is she has a high inflammatory load. I suspect that that's probably coming from the overgrowth of bacteria and candida in the gut. I think it's a GI related driver behind this inflammatory process. So we're obviously, one of our primary targets is going to be to address that candida and that bacteria. The other things is, there are these estrogens. So in the short term, what can we do to try to help clear these estrogens more efficiently? Well, one thing is the top priority there is to support the detoxification pathway, because I suspect that the estrogens are probably higher due to the inflammation, but due to an inability to properly clear them as well. So we're going to use calcium deglucarate, which is a form of calcium that we can take that's been shown to help neutralize that enzyme that's at a high level in the digestive tract, so that we can properly clear and eliminate these hormones. Then I think by doing that, I'm looking at using some compounds found in cruciferous vegetables like DIM and I3C, which are helpful at shifting the estrogen metabolism to a more favorable, less what we believe is a less dangerous pathway. So I don't want to get into all those details. I talk about that in other videos, but that's going to be something I think we should consider doing for a short term, right, while we're getting this bacteria under control and trying to lower these inflammatory levels, which the inflammatory levels are likely shifting some of these enzymes and contributing to higher estrogens. I think it's probably upregulating aromatase activity. It's probably creating some, this high inflammation is also creating some resistance to our insulin, because higher inflammatory loads decreases hormonal sensitivity. And we know this is absolutely true, where higher inflammatory loads decreases cellular sensitivity to hormones. So insulin is a hormone, and if you have decreased insulin sensitivity, you tend to make more insulin to try to stimulate, because the body will do that to try and stimulate the response, the response to insulin. And the body will do that if the blood sugar is going higher. So I think we can improve insulin sensitivity by lowering the inflammatory load. That'll lower insulin. That will improve blood sugar, her response to the insulin, and balance her blood sugar more efficiently, which is going to, I think, positively impact and lower aromatase activity, which will help to prevent this, I think, overconversion of her androgens, her testosterone and androstenedione, into estrogens, which are high. Okay? This is the adaptive physiology that I think is going on here. So it comes back to okay, address the drivers of the inflammatory process. Try to support as much as you can the things in the short term that are, a greater risk factor for her, that's going to help her more with symptoms. And then obviously you're going to drop off of some of those things that you're doing in the short term as they improve. So over a few months, right? There's a few other things there. It's complicated, but I've got several things here. We're changing diet. We're optimizing lifestyle. But these are the issues. This is the issue. These are the kinds of problems that are really happening to people, and you have to listen to some of these cases, and you have to understand some of the interconnectedness of the systems of the body. You have to have an appreciation for it, because it does not work independently. Your systems of your body do not work independently from one another. You can try to study them independently to better understand how things work, but once you kind of come back to looking at the trying to understand how the body works, you realize again that all these systems that you might study independently all have interconnectedness. And by no means do I have a mastery of all of these systems of the body and how they work together, but I have had the opportunity to learn from some people that understand it pretty well. At least I think they do. And I've got, I've had the opportunity to learn from some smart people that have taught me quite a bit. But this is kind of what I see in practice. This is the kind of stuff that we have to address if we're going to help people. So okay, I have definitely gone over my 10 minutes, and what I want to do is I just want to share this because, and I don't know if I actually made this clear or not, but the issues here with potential cancer, is really these estrogen metabolites. So if the body's not able to clear these estrogen breakdown byproducts, and I think I said this throughout the video, especially the 4-hydroxyestrone, the 4-hydroxyestrogens, those have been shown in the scientific literature to break the DNA bonds, to break the double strands of DNA, cause mutation, and contribute to cancers. Okay, so there's a lot there that you can a lot of problems there that can occur. So that's one of the connections here. So I wanted to share that, but definitely all of these, this is all, female hormone imbalances, cancer, poor thyroid hormone physiology, not feeling well in general. This is all, this is the perfect case to help illustrate these points. So just some of the ways that the physiology can break down. But anyway, I hope this has been helpful to everyone. If you have questions, comments, please do share them with us and let us know if we can help you out in any way. But I do appreciate everyone. Hope you all have a wonderful day, and I'll talk to you again soon. Happy 4th of July in the U.S., around the world. Hope you all have a wonderful day. I got to go work out, and I'll talk to you all soon.